Hi, everyone. My name is Gurja Basra, and I'm the Manager of Patient Programs, Research, and Advocacy at Lymphoma Canada. And I'm pleased to welcome you all to today's session titled Other Indolent Lymphomas, including Marginal Zone and Waldenstrom Macroglobulinemia. We appreciate those who have been able to join us live today to learn more about the disease-specific biology and diagnosis of this lymphoma subtype, as well as novel treatment options available for Canadians. Before I introduce the speaker, I just want to provide some guidance about the Zoom software for the session. So this virtual software does not allow you to share your video or turn on your microphone. Hence, if you have any questions, please save it for the Indolent Lymphomas Q&A session that follows this presentation. So without further ado, to introduce our speaker, today we have here Dr. Stakhu, who is a clinical professor at the University of Saskatchewan and malignant hematologist at the Saskatoon Cancer Clinic. She completed her Bachelor of Science, MD, and internal medicine training at the University of Saskatchewan, hematology training at Queen's University, followed by her fellowship at PMH in lymphoma and stem cell transplant. Dr. Stakhu has had several leadership positions, including provincial leader of hematology for Saskatchewan, the medical director for the Saskatchewan Blood and Marrow Transplant Program, and most recently, medical director of oncology at the Saskatoon Cancer Clinic. So thank you so much for joining us today, Dr. Stakhu, and I'll just hand it over to you.
All right, so here we go. I'm going to talk about Waldenstrom macroglobulinemia, which is a mouthful, and then marginal zone lymphoma. And so hopefully by the end of this talk, we'll understand what Waldenstrom's macroglobulinemia is. And I might just shorten that to say Waldenstrom's. And you'll see in the slides when I've written WM instead of typing out Waldenstrom's quite frequently, because it's a lot to type and a lot to say. We'll talk about who needs treatment and what treatment options there are for newly diagnosed and relapsed Waldenstrom's. Then we'll move on to marginal zone lymphoma and kind of the same thing, what it is, who needs treatment, and then what the options are for newly diagnosed and for relapsed marginal zone. So Waldenstrom was actually first described by a Swedish physician in 1944. And when he found that there was this hyperviscosity syndrome, and I will kind of outline that in a little bit, but that was caused by these abnormal lymphocytes, which is the type of infection-fighting cell that secreted immunoglobulin or an antibody, and in this particular case, IgM. It was associated with anemia or low hemoglobin, low red blood cells, and a large liver and spleen and some bleeding complications. So Waldenstrom's is quite rare. It's part of the indolent non-Hodgkin lymphoma cell family, probably an incidence of about 3 to 6 million per year. So in Canada, that gives us about 150 cases diagnosed per year in Canada. It only really represents about 2% of all lymphomas and kind of chronic lymphocytic leukemias. And it has a median survival of about 10 years, although I think that that's probably a bit of an older statistic, and we're hoping that it's more than that with some of the newer treatment options that are available. So Waldenstrom's is typically described as a disease with two problems. One is this cell that's in the bone marrow that causes problems, and the other one is a problem because that cell in the bone marrow secretes this antibody, this monoclonal protein called IgM. And as you can see there on the right, the IgM ends up being a pentamer. So it's got 5 little spokes. And when there's a lot of IgM, they actually clump together in the circulation, and that causes a lot of problems. So either you have what's going on in the bone marrow, and then you have what's going on because of the protein in circulation. And those two things kind of come together to cause the problems with Waldenstrom's. So if you have Waldenstrom's and you have that elevated IgM, as I just mentioned, because it's sticky, it can cause some problems in the blood circulation. It can get deposited into tissues, and when it's deposited, it can cause some troubles. And it also can cause some autoantibody activity. So it can stimulate the antibody to kind of go against other cells in the blood. And sometimes other tissues as well. So that monoclonal IgM protein can actually cause quite a few problems in the circulation. So as I mentioned, you need two things to make the diagnosis of Waldenstrom's. You need that cell, that abnormal cell that exists in the bone marrow. And you can see on the right there, some pictures from what the bone marrow might look like. Pretty much we say anything in hematology, if blue is bad, so there's a lot of blue on the screen there. So you need that presence in the cell, and then you need to be able to detect the antibody, the IgM antibody in the peripheral blood. If you just have the cell that you've identified in the bone marrow, but you don't have the IgM in the peripheral blood, we don't call that Waldenstrom's. That's just a lymphoma or a lymphoplasmacytic lymphoma. Rarely you can get those cells in the bone marrow not making the IgM. It will make the other type of antibodies that we have, IgA or IgG, but that's really a rare type of all of the different lymphomas caused by that lymphoplasmacytic cell in the bone marrow. So again, you need two things. You need to have that cell in the bone marrow, that lymphoplasmacytic cell, and you need that IgM monoclonal protein or that antibody that's in the blood and circulating around. So just in case for those of you that are watching and you've heard this mentioned in the clinic or you've done some reading, there are some specific mutations for Waldenstrom's that help make the diagnosis and sometimes determines how well people are going to respond to specific types of treatment. So we have this MYD88 gene, and it's present in more than 90% of patients. And if there is the mutation in MYD88, it actually can be helpful in differentiating similar types of cancers. So sometimes the cells look like lymphoma, but not enough differentiation to be able to say, it's marginal zone or it's lymphoplasmacytic. So we'll send off to look for this type of mutation. The mutation is not specific for lymphoplasmacytic lymphoma. Sometimes you see it in other B-cell lymphomas and maybe just the precursor condition. But if you have it, it's very helpful. And having that mutation actually seems to confer a favorable prognosis. The opposite is true of the CXCR4 gene, which is present in about 30 to 35% of patients. If you have this mutation, it's actually the opposite. It's associated with higher disease burden at presentation, higher serum IgM levels, and oftentimes people present with this hyperviscosity syndrome, which I'm going to outline in a minute. It doesn't seem to have an impact on survival, but maybe has some implications for how well you're going to respond to particular types of treatments, and in particular, ibrutinib as a targeted therapy. So just to kind of show here that when you have the MYD88 mutation and then you have the CXCR4 mutation, you have different permutations. So you can have MYD88 mutated and CXCR4 negative, best case scenario. If you have MYD88 unmutated and CXCR4 mutated, worst case scenario, and you can see what happens in terms of different treatment options. The bottom blue line, people drop off that curve very quickly, depending on that mutational status. Not quite helpful in predicting survival yet, though. So what else might we do if we think somebody has Waldenstrom's? So we want to be able to look at where that protein might be in the body, and that's going to be kind of two places. Either in the serum, in the blood, or in the urine. So sometimes we'll do a urine protein electrophoresis. We'll look at beta-2 microglobulin and LDH, and those can be a marker of tumor burden. Sometimes we'll look for CT scans and PET scans to look for other areas that the disease might be, and then particular blood tests to determine if that antibody, that IgM, is causing some trouble. So we'll do the direct antiglobulin test, which might indicate that there's some autoimmune potential to cause low blood. We'll look for cold agglutinins and cryoglobulins, which tend to happen when the body is cold. And we'll look for how thick the blood is because of that IgM protein and kind of how viscous it is, which can cause a lot of problems because the circulation isn't moving around. If indicated, we'll do an eye exam, what's called a fundoscopic examination, where they shine the light in the eye, and we'll try to look for evidence of kind of either where the blood has got so sluggish it's almost been a little stroke in the vessels in the eye, or other serums of having that elevated IgM causing vision problems. We might look for elements of the IgM causing problems with the nerves, and so we might do an EMG. We might do a fat pad biopsy, which is taking a little piece of the fat that's underneath the skin in the abdomen to see if there's something called amyloidosis, and that happens if the IgM protein forms fibers in the body and can deposit in tissues. There's a very rare condition where you get the IgM causing problems in the central nervous syndrome. And sometimes we need to do a lumbar puncture or a spinal tap, and sometimes an MRI. And then iron studies. Oftentimes you have enough iron, but you can't use it. And so you might see what looks like iron deficiency in the body, particularly if somebody has a low hemoglobin, and oftentimes the iron studies and increased hepcidin levels can help us pinpoint what we might need to do as an intervention. So I put this up here just so that you could see some of the different diseases that might be in the diagnosis pathway to get us to Waldenstrom's, and some of the different ones that might confuse us with the diagnosis. And so really in the left column where it says disease, you'll see Waldenstrom's. You might just have a precursor condition called MGUS. It might actually be multiple myeloma. It might be a type of chronic lymphocytic leukemia. It might be marginal zone lymphoma or mantle clinical features, so how people present, what the bone marrow looks like, and then some other kind of genetic tests or markers, how we put the pieces of the puzzle together to actually get to the diagnosis of Waldenstrom's versus some of these other diseases. So patient presentation, that actually quite vast and can vary quite a bit. So I kind of present two patients here. Patient one, 67-year-old male. He went for a routine physical, otherwise was in good health, no symptoms. They got some routine laboratory investigations, was found to have an anemia or a low hemoglobin. Everything else was fine, but because he had a bit of anemia, that led to a few other investigations. He was found to have that elevated IgM and a monoclonal protein. It was elevated. Subsequent investigations led to a bone marrow biopsy that showed 20% of those lymphoplasmacytic cells. Makes the diagnosis of Waldenstrom's, went to do a CT, and there's no other evidence of lymphoma or those cells. That's how people can present. So on the opposite side of the spectrum, you have a 67-year-old male who has severe fatigue, nausea, visual difficulties, increased confusion and drowsiness. Do some blood work to try to figure out what's going on, and you can see he has quite a low hemoglobin and then he's anemic, low platelets. The IgM protein is quite elevated at 66. You go to see if that IgM protein is causing problems by seeing how viscous or how thick the blood is, and it's elevated. Because of that, he's had some leg ulcers. You do a bone marrow, and he shows 80% cells. And then you go and do a CT scan, and not only are you having problems with the bone marrow and the elevated IgM, but now you have that particular cell causing problems with lymph nodes and depositing in the spleen. So very vast, two different presentations. So again, how can patients, when they have symptoms from Waldenstrom's, present? There was a bit of a retrospective review that looked to see what happened for patients who had that IgM monoclonal protein at a level that was above 30 grams per liter. And when they went to the bone marrow, they saw more than 20% of those bad cells. And when we looked at that 217 patients that met that criteria, just over 25% were actually asymptomatic, which definitely can happen. Close to 40% had anemia. Hyperviscosity was a problem in 30%. We call them B symptoms or constitutional symptoms. So you get fevers, night sweats, and weight loss. In about 25, bleeding complications, and then neurological symptoms. So if you have symptoms, those seem to be the most common in terms of how people are going to present. Just wanted to mention that hyperviscosity syndrome, because that certainly seems to be one of the most problematic parts of having an elevated IgM or that monoclonal protein, and something as a hematologist really worries me, because if we don't get on top of it, patients run into a lot of trouble. And so you can get some bleeding, and particularly in those areas, we call them mucosal areas, so the gums and the nose and the GI tract. You can get some bleeding. You get the visual disturbances. As I mentioned, that IgM can cause actually little clogs and vessels into the eye, and that can cause some retinal hemorrhages. You can get some swelling of the disc in the eye and some blurred vision. You can get neurologic concerns, anywhere from some fatigue to some bleeding in the brain, some seizures, or some altered balance and difficulty walking. And sometimes you can actually get some heart failure, so some heart concerns. And really, when we look to see if somebody has hyperviscosity syndrome and symptoms, it's kind of a triad. So you get mucosal bleeding, visual disturbances, and neurologic complications. And to us, that's a hematologic emergency, and something we need to do something about quite quickly. So just some pictures here, so you can see that hyperviscosity, or that thick blood due to that protein, can cause some leg ulcers because you've blocked the circulation. You can get some, we call it acrocyanosis, or again in the fingers there, because you block the circulation being able to get to the fingertips. You can get some troubles in the brain, kind of like little stroke-like things. And then in the eyes, you can get some blocks of the blood vessels there, and then you can run into some trouble. Other things that having that elevated protein can do, you can get what we call cold agglutinin disease, or cryoglobulinemia. And that's really the IgM causes the red blood cells to clump together and sometimes break up and cause hemolysis. And that happens when the body can get cold. And so that happens in the peripherals, like periphery, like your fingers and your toes, and then you have trouble with circulation. As I mentioned, you can get actual deposits of some of the IgM things into tissues, and you can see some of the skin infiltration there. And then that Bang-Neal syndrome, which is pretty rare, but quite scary if you get a central nervous system involvement by that monoclonal protein. So what can we do for treatment? Again, it's an indolent lymphoma, and you would have heard, if you attended the Indolent Lymphoma 101 session, that it's not curable. And so we generally only treat these conditions if they're causing problems. And the goal of treatment is to stop the problems. So if patients are asymptomatic or not having any problems, we can observe and we can watch, and we don't have to jump on it too quickly. If they're having trouble from that IgM and that hyperviscosity syndrome, we want to thin the blood and take out that antibody. And we do that by something called plasmapheresis. We do use monoclonal antibodies, and the prototypic one would be rituximab as a monoclonal antibody. Oftentimes, we'll combine the antibody with a chemotherapy backbone, most commonly being bendamustine, and that's chemoimmunotherapy. Some of the newer treatment options, and I'll mention them in a minute, proteasome inhibitors, such as bortezomib, some of the newer oral targeted therapies, and there's 3 new kids on the block. You've got ibrutinib, acalabrutinib, and zanubrutinib. Rarely we will do an autologous stem cell transplant, or even an allogeneic stem cell transplant. So either you get cells from yourself, or we get cells from a donor to try to turn off the Waldenstroms. And importantly, clinical trials. And I mention that because Waldenstrom's is pretty rare. And so treatments are generally adopted from data where we do clinical trials that really take a smattering of indolent non-Hodgkin lymphoma patients. So commonly, there'll be trials for follicular lymphoma, the most common type of indolent lymphoma. And we'll throw in some patients with Waldenstrom's, because there aren't a lot of patients with Waldenstrom's. And then we try to extrapolate the findings of that lymphoma trial in terms of what we can do for Waldenstrom's patients. So we don't have a lot of times great individual data, and a lot of it is extrapolated. So if we ever do get a clinical trial specific to Waldenstrom's, we get quite excited, because we hope that that's going to be very specific for our patients. So as I mentioned, active surveillance is still a common option for asymptomatic Waldenstrom's patients. It's not curable, but it's treatable. And again, the main goal is to control the symptoms and improve quality of life. I kind of showed you that one retrospective study of 217 patients, and that's just kind of shown again here, 25 to 30% won't have symptoms when they get diagnosed. Half of those patients can be watched for years without requiring treatment. If you get diagnosed later in life, over the age of 70, a good proportion of those people never require any therapy. There isn't any survival advantage that we have seen yet in studies that indicate treating patients if they don't have symptoms provides an advantage over just the watch and wait approach. Therefore, you need to have regular visits to make sure we're not missing any signs or symptoms of active disease, looking at the blood counts and those IgM levels. And again, as a surrogate marker of what's happening in the bone marrow and how much of that lymphoplasmacytic cell is there, you can follow the levels of the IgM protein or the monoclonal protein in the blood to kind of track how much burden of disease you might have in the body. And so here are some kind of validated indications for treatment or consensus guidelines, clinical indications for initiation of therapy, and I've mentioned a lot of them today. Hyperviscosity, those constitutional symptoms, peripheral neuropathy, a big spleen or a big liver, and then there's some laboratory indications to start therapy. So if you have symptoms from those, IgM proteins depositing in the peripheral vessels when things are cold, if you're having a low hemoglobin or a low platelet count. So there's some laboratory indications to start therapy too. So I mentioned plasmapheresis, and that's when we have that IgM causing the blood to be thick or quite viscous. That's when we hook patients up to a machine that you can see there on the right. It kind of looks like a dialysis machine. And we really try to remove the volume of plasma from patients, and in doing so, remove that IgM that exists in the serum. We have to give patients some plasma back. We generally need to do this 1 to 3 times to kind of get rid of enough of that monoclonal protein to make those symptoms go away. And we really target the amount of plasmapheresis you do to what is happening with symptoms for patients. So there are some risks for plasmapheresis. That's why we kind of have a pretty stringent criteria. And you can see here, sometimes we'll drop the calcium levels. As you can imagine, we're pulling out plasma from the body. We are replacing it, but sometimes you can drop your blood pressure. Rarely you can have some trouble when you put in the big catheter that you require as a big IV. And sometimes you can, if you dilute out your good clotting factors, you can get some bleeding. So we put this picture up because this is exciting. We are learning a lot more about the biology and the pathways of how that lymphoplasmacytic cell survives and all the different mechanisms that target that cell to be able to replicate and keep making more of itself. And as you can see, all of those different pathways are ripe with us being able to determine a way to stop it. So the boxes that have the red outline are all the different types of drugs that are either available or in study or that are coming that might be specific targets to stop the pathway that makes the cell rapidly divide and cause problems. So sometimes we do use those mutations that I talked about at the beginning to determine what pathway we go down for management. And really, if you have kind of that good risk disease where you have that MYD88 mutated, you have no mutation in that bad gene, that CXCR4 gene, oftentimes you can use a targeted therapy alone or maybe some chemoimmunotherapy like bendamustine and rituximab. However, if you don't have the good mutation and you have the bad mutation, sometimes you need to be a bit more aggressive and you need to do some plasmapheresis. You need a rapid response. Patients are having a lot of trouble with that elevated IgM. So sometimes we do use those mutations to kind of help us figure out what direction we're going to go in. I mentioned the rituximab as a monoclonal antibody. It's used all over treatment for B-cell lymphomas and including Waldenstrom's, either on its own or in combination with chemotherapy. Sometimes if that IgM level is high and you give rituximab, you can get a transient increase in the amount of IgM. And when that happens, you get that hyperviscosity. And we don't like to see that happen. So if the IgM value is already at 40, either we will start a different treatment to bring that level down and then do the rituximab, or we might even do some plasmapheresis and remove that IgM so that we can start the rituximab. More commonly now, we combine the rituximab with either that chemotherapy backbone or one of those new novel treatments that I mentioned earlier. So here's chemoimmunotherapy. Most commonly in Canada, bendamustine and rituximab is the backbone. As I mentioned, a lot of times we'll omit rituximab for cycle 1 to decrease the risk of having that IgM flare. Remember that a lot of times we don't get a lot of patients in the clinical trials because it's pretty rare. So there is some data from a trial called the STILL trial. There are only 20 patients in each arm, but if you did bendamustine and rituximab versus a more aggressive chemotherapy, you actually did better with just the bendamustine and rituximab. Again, if you don't have that MYD88 mutation, your progression-free survival might be a little bit low, but the median progression-free survival with the bendamustine and rituximab was close to 70 months. You can do some maintenance rituximab, and there's some conflicting evidence as to the benefit of doing some treatment doses of rituximab and then maintaining that response with your maintenance rituximab, generally given once every 3 months for 2 years. It looks like if you looked back at patients who got this, there was some progression-free survival benefit, which is either not progressing with your disease or not running into trouble from that disease, but really didn't appear to have an overall survival benefit in the end. So the jury is still out. We generally do it, particularly if we do rituximab alone, or we do bendamustine and rituximab. Generally, we will add on the maintenance for 2 years after we finish the chemotherapy. I mentioned some of the targeted agents, and a couple of these are listed here. We have subcutaneous bortezomib, and you have intravenous carfilzomib. And then you can combine those with kind of a whole pile of different things. And all of that is being studied right now. The proteasome inhibitors can cause shingles and zoster reactivation. And so anytime we give people a proteasome inhibitor, we like to make sure that they're on some type of prophylactic antiviral. And then now the new kids on the block, the targeted oral therapies, and I mentioned the 3 of them, the ibrutinib, acalabrutinib, and zanubrutinib, really seem to do well if patients have that MYD88 mutation, works well to rapidly reduce that IgM level. You get improvement in your hemoglobin and often durable remissions. These are ongoing, continuous therapies, so it's not 6 months or 12 months. You keep people on them for as long as they're working. Might not work as well if you don't have that specific mutation, but that doesn't mean we don't give it. Sometimes the side effects are related to just having this class of drug, and sometimes there's specific side effects with each one of those drugs. It's nice that we have availability of at least 1, if not 2 of those in Canada, dependent on different funding in different provinces. But sometimes you can pick the one that you like based on the patient profile and the side effect profile. Ibrutinib, as is listed there on the bottom, was the first drug ever to be approved by the FDA in the United States to treat Waldenstrom's macroglobulinemia. So ibrutinib, again, as I mentioned, the clinical trials are pretty small. So there are 3 single-arm trials, a total of 124 patients. Great response rate to the drug of more than 90%. No complete responses, but you don't necessarily need that if the response continues over time. Again, you can divide patients up in those trials as to their mutational status. whether they have that good mutation and bad mutation and what combination that is. Just to point out there, if you have the good mutation in MYD88 and you don't have a mutation in the bad gene, you do pretty good at 70% progression-free survival. But if you don't have the good mutation and you have a bad mutation, you don't do very well. There are some bigger studies coming out with ibrutinib as well. So that's an upfront treatment. What do we do when patients have relapsed or refractory disease? Because almost everybody, once you need treatment once, will end up needing a second treatment because we can't cure this type of cancer. There isn't really standard treatment right now in the relapse setting. So the choice of treatment will depend on what you got initially, how well you tolerated it, and how long that treatment lasted. So sometimes if you got bendamustine and rituximab and you're relapsing 3 years later, you could try the same chemotherapy backbone, but data continues to emerge every day, and we've got lots of different options now available for the relapsed refractory setting. There is still the option of a transplant, but it's generally reserved for a younger and fitter patient because it is quite intensive. So I think I've kind of talked about ibrutinib here. I'm going to skip over this slide. There is a comparison of zanubrutinib and ibrutinib, both of that oral targeted agent, specific to Waldenstrom's, and we got pretty excited when we had an ASPEN trial dedicated to Waldenstrom's macroglobulinemia. This is in the relapsed and refractory setting, and looked at the different mutations and then broke patients up into different arms. And what we essentially saw was that zanubrutinib was as good as ibrutinib in efficacy, but might be even tolerated better depending on the side effect profile. So as I mentioned, stem cell transplant is an option. It's better if you do it earlier in the disease course, but some of these studies were done before we had the targeted options available. If you survive the transplant, you actually do pretty good, a 5-year overall survival of 62% for an allo transplant, but you do have a high non-relapse mortality. So not that the disease comes back, but you have problems with infections and other reasons that you have trouble with the transplant. So just in summary, I think discovery of those two genes and us being able to kind of identify prognosis and treatment pathways leads to a more accurate diagnosis and targeted therapy. We have trouble with that IgM-related protein, and it continues to be a significant cause of problems with Waldenstrom's. And, we're getting excited because there's some phase 3 trials specific for Waldenstrom's that will help determine future treatment strategies. So I'm going to take a quick sip of coffee and then just move on to marginal zone lymphoma. So it's the second most common type of indolent lymphoma. It's about 7% of all of your non-Hodgkin lymphomas, and we can break them up into 3 distinct types. So you have your Malt lymphoma, so mucosa-associated lymphoid tissue, and I will talk about that a little bit more, but that's essentially a lymphoma in areas where you have lymphoid tissue depositing kind of in the mucosal areas, and we'll talk about some of that. And then you have it in the spleen, about 20% of all marginal zone lymphomas, and then just in lymph nodes is actually fairly rare. It's about 10%. And you can see it's not as distinct as we'd like it to be, even though we say there's 3 distinct subtypes. There is some overlap amongst all of them. So there are possible genetic and environmental risk factors. We do know that particular infectious agents can lead to marginal zone lymphoma. I'm going to get into that in a second. There are autoimmune disorders that can drive particular types of marginal zone lymphoma, such as Sjogren's syndrome, lupus, and Hashimoto's thyroiditis. And then some environmental factors increase the risk, although the relative risk is really quite small. So I put hair dye there, but don't think that if you are getting your hair dyed a lot, you are going to get marginal zone lymphoma. The actual risk is pretty low, but there is an association of hair dye and development of marginal zone lymphoma. So let's go into the first type, the Malt lymphoma, or again, mucosa-associated lymphoid tissue. You can get that in the stomach, you can get that in the eye, the salivary glands, the thyroid. So some of those areas where you might need some lymphoid tissue to stop infections, that's where you can actually get the lymphoma. Most of these are actually infection driven. So if you have gastric malt lymphoma, a lot of times that's caused by a particular bacteria called H. pylori. If you have eye or ocular lymphoma, sometimes that's caused by a particular chlamydia infection, and I can never pronounce it right. It's chlamydia psittaceae, sometimes from birds. In the skin, Borrelia burgdorferi, and in the lung, I'm not even going to try to pronounce that one. There is a risk scoring system for mucosa-associated lymphoid tissue lymphomas. Really, 3 factors have been born to kind of put people at higher risk. So advanced stage of the disease, how much disease you have, age over 70, and an increased LDH, which is a blood marker. So just specifics on gastric malt lymphoma, as I mentioned, if you're H. pylori positive, a lot of times you can get rid of that lymphoma just by getting rid of the H. pylori. And we have what we call triple therapy. It's got a couple of antibiotics and a proton pump inhibitor. It can take a while to work, so that we say, wait at least 3 months before you go and get the scope that looks with a camera into the stomach to see that it has worked. And sometimes you need up to 12 months to determine if it's really worked and it's gone. You can get a particular genetic change within that gastric malt lymphoma, and sometimes eradicating the H. pylori doesn't work. Even if you're H. pylori negative, you still might respond to trying to get rid of the H. pylori. And so we still will try that up front. Sometimes a different antibiotic works, but at the end of the day, we do know that we can radiate isolated gastric malt lymphoma that doesn't have the H. pylori. And we do that with an intent to cure. It's limited stage radiation. We do it so that we can get rid of it and it doesn't come back. For the non-gastric malt lymphomas, those other ones, the eye and the skin that's driven by an infectious agent, generally trying to get rid of that infectious agent doesn't work as well as if you have that gastric malt lymphoma. And so we have tried the ocular lymphoma to try a series of antibiotics. Sometimes we do end up going and doing localized radiation with the intent to cure. If you have an advanced stage Malt lymphoma, so it's not just localized to one particular area, like just the stomach or just the eye, again, if it's not causing any problems because it's an indolent lymphoma and we can't cure it, we just adopt that wait and watch approach. And overall survival of Malt lymphoma, advanced stage Malt lymphoma, is about 85% at 4 to 5 years. So that second type now that I mentioned is splenic marginal zone lymphoma. It's about 2% of all lymphomas, but about 20% of all the marginal zone lymphomas. A third will have no symptoms. And again, asymptomatic indolent lymphomas, we just do the watch and wait approach. It's very appropriate. 2/3 of patients will present with splenomegaly, so a big spleen. You'll see some increased lymphocytes, so the one particular type of infection fighting cell in the blood. You might have some low blood counts, anemia, low platelets, low neutrophils, those infection fighting cells. And sometimes you can see autoimmune complications. So you produce an antibody that fights your own cells, such as autoimmune hemolytic anemia. So you produce an antibody that breaks up your own red blood cells. There is an association with hepatitis C, and oftentimes we'll look for that to make sure that's if it's there, we want to make sure we're treating the hepatitis C. We don't actually need to go and biopsy the spleen. A lot of times people have the characteristic markers in the blood lymphocytes that will say that it's marginal zone lymphoma, particularly if there's a big spleen and then you have the cell in the peripheral blood. So usually you don't need to go and biopsy the spleen to make the diagnosis. And then the last one is nodal marginal zone lymphoma. So the rarest kind of marginal zone lymphoma, 10% will have IgM secretion, make a monoclonal antibody. So sometimes it does get confused with Waldenstrom's, and that's when you go and you look for those genetic changes. And generally they don't have the MYD88 mutation. So in terms of management, again, watch and wait for a lot of patients, particularly if they have more than just localized disease. It can be indolent. You can be asymptomatic for years and not need anything. Symptoms might be a large, bulky spleen, low blood counts, those constitutional symptoms, so fevers, weight loss, and night sweats, or big, bulky lymph nodes that are causing problems. Again, similar to Waldenstrom's, marginal zone, not that common. And oftentimes when we look at clinical trials, we lump marginal zone in with the bigger patient population of follicular lymphoma. And you put that with the fact that, we've got a bunch of different presentations for marginal zone lymphoma, which means we don't have a complete understanding of the biology. We come up with really no current standard of treatment, but generally treat it like an indolent lymphoma. So watch and wait is appropriate. You can do local radiation therapy. Sometimes if you needed to, you could actually take out the spleen. All of this is for local control. Single agent rituximab can work. Combining rituximab with chemotherapy, I'm starting to sound like a broken record. It's very, very similar across the indolent lymphomas. There's only one trial in Malt lymphoma that looked at rituximab versus chlorambucil versus rituximab and chlorambucil. There was a benefit for adding rituximab. There's other types of chemotherapies that you could use, but there's that pretty old. You can see they're back in 2002 and 2004, because some of those newer targeted agents, and I'll mention that in a second, have come into play now. And so being really aggressive with chemotherapy now is pretty rare. We do use R-CHOP sometimes if the patients have transformed from the indolent marginal zone to a more aggressive lymphoma, or things are bulky and you want to get the disease under control quite quickly. So 4 weekly doses of rituximab, and then if you respond, you can get maintenance rituximab. Rituximab and chemotherapy will increase your progression-free survival, not overall survival yet. You can take out the spleen. Keep in mind that if you do local control for some of the Malt lymphomas, whether that's radiation or try to treat with an antibiotic, it can take up to 12 months to show that you've responded. People always ask about scans. Do we do a CT or do we do a PET scan? PET scans aren't routinely helpful because oftentimes you get poor uptake from the scan, and so it might not give you a complete picture of where the lymphoma is. Sometimes we do them routinely because they're just part of a lymphoma workup, but you kind of need to do a complete picture and not rely solely on the PET scan to determine the area and extent of disease. So again, similar picture to Waldenstrom's, and it's really a testament to how much we're now understanding the disease biology. Still not complete, but we're getting there. It's a B cell, and so all of the different ways you could stop replication of that B cell, blocking those pathways, or even with some of the receptors on the outside of the cells, all of those are fair game as targets for being able to stop that cell. And I kind of put this up here like I did last time. If you just look at the class in the left-hand side there, we have those BTK inhibitors, ibrutinib and zanubrutinib. You have a few of the new kids on the block. They're PI3 kinase inhibitors. And then maybe even some CAR T cells, some new immune type therapies coming. So B cell receptor signaling is really a critical step for marginal zone lymphoma development. And if you can stop that signaling, you do really great in getting control of the disease. So ibrutinib, again, we use it in a lot of B cells. In relapsed refractory marginal zone lymphoma, a small patient study, you get about 50% of people responding and a median progression-free survival of 15 months. The overall survival, however, hasn't been reached. And remember, this is in relapsed refractory disease. There's some thought about if you combine 2 targeted agents that you get a better overall response, such as ibrutinib and another targeting agent called venetoclax. There has been, again, a phase 2 study using zanubrutinib, so another bruton tyrosine kinase inhibitor in relapsed and refractory marginal zone lymphoma. And again, exciting because it was dedicated to marginal zone lymphoma. With this study, we saw that we did well with high-risk features, which oftentimes we worry about. Elderly patients, even those over the age of 75, heavily pre-treated patients, so not just after one line of therapy, but two or more lines of therapy, refractory disease and nodal disease. And as you can see, after a median follow-up of about 15 months, you had a really good over response rate, 70%, a complete response rate of about 25%. Your median progression-free survival and your duration of treatment were not reached. Some treatment discontinuations, but really not thought to be due to zanubrutinib. You do get some adverse events from all of the all of the drugs in this particular family. And at the time the trial was done, COVID was quite prevalent. And so we had a couple of people die from COVID, and there's occasional cardiac signals. But because of this study, zanubrutinib has really become the go-to for relapsed refractory patients with marginal zone lymphoma. So just the last couple slides on some of the newer kids on the block. So I mentioned those PI3 kinase inhibitors, small studies, but really looking good. I can't even pronounce them. Copa and Lysib, 23 patients in a study, 2-year overall survival of 83%. This led to an FDA breakthrough designation. And then CAR T, kind of that really cool immune therapy that's coming right now for lymphomas and in some places some myelomas, hopefully soon for the indolent lymphomas. But 22 patients, small study, early days because the follow-up is only 12 months, but good progression-free survival at 12 months, a little bit higher than expected neurologic toxicity, but hopefully they can refine that CAR T over time and it'll get better and better. So just in summary, so Waldenstrom's, again, symptoms are really due to the IgM causing problems in the peripheral blood, and then the bone marrow infiltration. And some of the novel B-cell signaling therapies are coming, which is really exciting. Your marginal zone lymphoma, you have 3 different types. You have your Malt lymphoma, Splenic lymphoma, and nodal lymphoma. The treatments are often extrapolated from the bigger indolent lymphoma trials, such as follicular lymphoma, but we are getting some independent trials now for marginal zone. And again, those novel B-cell signaling therapies are really exciting for treatment of both of these 2 types of indolent cancers. And with that, I'll sign off.
Thank you, Dr. Stacku, for that wonderful presentation. We appreciate your thorough review regarding disease biology, diagnosis, and treatment options for Canadians. Now I'd like to direct the audience to attend the breakout session after this presentation to have your questions answered live. Thank you.